It's problems of uh, energy use or energy production and blood flow. And insulin resistance will impact both of those. In particular, the cells of the ear that would be involved in hearing that you would know more about than me, given your training. They are high metabolic rate cells. They have a high demand for energy, and part of that demand is met by glucose. Well, as the body's becoming insulin resistant, then those cells become less capable of utilizing glucose for energy, and the cell is forced to rely on other forms of energy. Now, normally this wouldn't be a problem. Most cells, including these of interest, could just shift over to, say, fat oxidation and start burning fat for fuel. However, the elevated insulin that comes with insulin resistance tends to preclude fat burning. It wants to try to force a cell to rely more heavily on glucose use rather than fat use. And the net effect of this, with regards to the bioenergetics of the cell, is that it starts producing much higher levels of reactive oxygen species as you're forcing these cells to rely much more heavily on the mitochondria, which of course is the site of fat burning, if you will, or fat use. So we have this much higher rate of production of reactive oxygen species, which can activate apoptosis and the death of some of those relevant cells of hearing. And we have the insulin resistance compromising blood flow. This is a phenomenon that happens to varying degrees throughout the entire body, but it's particularly relevant in these cells of very high metabolic rates. They have a high demand for oxygen and the nutrients that the blood is bringing to them. And as the blood vessels in the body, by extension, through multiple mechanisms, starts to become insulin resistant, what should have been dilated, well-flowing blood vessels become very constricted, flow compromised vessels. And as the volume of the blood vessels is narrowing, then the pressure starts to go up. We have higher blood pressure. That can, of course, induce some damage to the fine capillaries in the ear tissue. But also, it just means less blood flow. And once again, we have a higher tendency for the cells to undergo apoptosis, or basically, we start killing off the cells that we need for hearing.
When you can't get blood to a tissue, it's not going to work properly. And in really small vessel areas like the cochlea, which is, the site of our hearing, our balance, these small perturbations in blood flow can have a massive, massive impact. And when you're getting ischemic, cell death events from lack of blood flow in these tissues, it makes sense logically that would lead to something like early hearing loss. And having seen so many patients in the ENT clinic that are dealing with hearing loss, it can be really a huge change in quality of life when you can't communicate properly. And to know that there's actually, and I think the vast majority of people think this is something to do with aging. Like this is just part of old age. But to know that there's possibly a modifiable factor to this, not just, stay away from loudspeakers at concerts, but actually that what you're putting in your mouth can have an impact on this over time, I think can be really empowering to people because when you're just told this is the way it is, you're getting older, there's not much we can do there.
And my message in general is that when we acknowledge a metabolic underpinning to so many of these chronic disorders, then there is in fact a ray of hope there, because if there is a metabolic origin, then there can be a metabolic solution, because we can intimately, exquisitely, and rapidly start to change metabolic health. And thus, the consequences of poor metabolic health are also, to a very large degree, changeable. Correlation between insulin resistance and tinnitus is remarkably high, where it's almost, it's very uncommon for someone to have tinnitus and not have some underlying metabolic problem, namely insulin resistance. This is an area where there's, again, not too much confirmed, but part of the connection between the two is thought to be a result of insulin changing the membrane potential, the nerve conductance, or the sending of a signal along neurons within the ear, within the cochlea. And in particular, insulin is known to affect the sodium-potassium ATP channel, and that's a little granular for most of the listeners, but basically, when we're sending a signal along a cell, like a neuron, we're sending that signal by nature of us rapidly shifting ions, positive and negatively charged molecules, almost like we're sending an electric signal in a way. And insulin will regulate some of the primary channels that are opening to allow these ions to move across, sodium and potassium in particular. Insulin is known to alter the rate at which that's working. Well, in insulin resistance and hyperinsulinemia, this is something that becomes actually overactive. And so it can disrupt the conductance of the nerve signal in the cochlea, which it almost makes it potentially hyperexcitable, and what should be a quiet nerve conveying no sound at the moment becomes a bit of a hyperactive nerve, giving you a lot of static or that ringing.
in the book, I recall that you mentioned that 92% of people with tinnitus, which is ear ringing, have hyperinsulinemia.
Yeah.
And then of Meniere's disease patients, which can be a debilitating ear disorder that involves ear ringing, 76% of patients with Meniere's were also insulin resistant. And something that was fascinating is that in the studies that were linked in the book about ear ringing and hearing loss and Meniere's disease, many of these studies were not looking at a diabetic population. They were
Right.
looking at a pre-diabetic or non-diabetic population that had high insulin levels, which I think is incredible. This is not, I mean, this could be applying to people who their doctor has never told them they had a metabolic
Mhm.
problem. But of course, we know that hyperinsulinemia can happen years, if not decades, before we actually see the changes in glucose on our standard lab tests. So this is not just relevant to people who are out there who have a diagnosis of diabetes, but for people who may be on that earlier part of the spectrum. You know, one of the reasons I actually moved away from ENT towards a more root cause approach to health, ultimately functional medicine, and then starting levels, actually related to GERD, because we were basically so often prescribing super high dose proton pump inhibitors,
Mhm.
like omeprazole, to basically just totally shut down the acid production in the stomach, as a quote unquote treatment for this condition. When really, of course, that's not doing anything to address what's maybe leading to the symptoms in the first place, which we know is very related to diet and lifestyle and weight and other factors that are modifiable. But that really strong bias towards just shut down the acid, give them a
Yep.
heavy duty maximal dose twice a day. A lot of these pills have never been studied for long term use.
Mhm.
We know that reducing the acid in the stomach has a huge impact on digestion, absorption of minerals and vitamins. It has long term outcomes, but we still kind of give these people these large prescriptions, and they're on their way.
Lest people think that the problem would stop at just, say, heartburn, there are even more catastrophic consequences to chronic GERD, like it converting or leading into something called Barrett esophagus, which then is one step away from esophageal cancer. Basically, once you get to that point, your risk of developing cancer at the lower part of the esophagus, right above the stomach, is like 30 times higher than normal. So if someone's experiencing chronic heartburn, that's more than just feeling a little uncomfortable. You could really be flirting with disaster. So insulin does numerous things. And in the case of the person who's insulin resistant, I think there's probably two relevant variables here, just off the top of my head. One would be that insulin does, in fact, alter the production of hydrochloric acid. It might be making the stomach a little more acidic, which could aggravate not only the stomach, but potentially, splashing the chyme up. Now, and that leads me to my second point. Normally, the the stomach is separated from the esophagus in large part due to the presence of the diaphragm. The diaphragm, which is that kind of primary breathing muscle, expanding the volume of space for the lungs for us to breathe. What can happen is that a portion of the stomach can bulge up past the diaphragm up into a space that should have been just relegated to the esophagus. So we sort of lose the functional sphincter, or the functional narrowing of the esophagus when it goes from esophagus into stomach. When you've had a portion of the stomach bulge up, something called a hiatal hernia, as it's bulging up past the diaphragm, now you have all the chyme, or all the very acidic contents of the stomach, splashing up into the esophagus much more easily. How this would be connected is that a person who has more fat mass, it doesn't even have to be in the visceral space, but even in the subcutaneous space around it. But the more fat mass you have in that abdominal space, let alone in the abdominal cavity or the visceral fat, the more pressure you have. And so you are pressing the intestines, pressing the stomach and anything else around there, the kidneys, the liver, etc. And there's only few places for this to kind of bulge into or herniate. If something's herniated, it means it's one thing moving into the area of another thing. And so pushing the stomach up through the esophagus might be a consequence of really increasing the intra-abdominal pressure. And now you're just forcing the intestines to go somewhere. And I guess it could be a prolapse, down, or it could just be a herniation up through the diaphragm. This is something that is known to happen in women with pregnancy, entirely a consequence of a higher intra-abdominal pressure because of the growing fetus. The same thing can happen with obesity. Insulin alters the rate at which the liver is producing cholesterol. And we know the bile is enriched with cholesterol. So bile itself is what the gallbladder is holding onto, are all products of what the liver is producing. So the liver and the little gallbladder kind of tucked beneath the liver in a way, it's receiving everything that it's supposed to hold from the liver. It's getting water from the blood, so there's water there. And then there is cholesterol, there's the bile salts, and a handful of other little things. But cholesterol is a primary component of it. In hyperinsulinemia, which exists in insulin resistance, it's accelerating the production of cholesterol from the liver. That means it is increasing the cholesterol in the bile, literally making the bile more thick or sludge-like, as they say. And the higher the concentration of the components are getting in the bile, what had been a nice dissolved kind of solution starts to have this condensing of molecules. And the higher the cholesterol is getting, the more these stones start to form. Now, at the same time, well, tragically, we've given people the perfectly wrong advice for decades now. By telling them to eat low-fat, low-calorie diets, we are basically ensuring that the gallbladder stays full as long as possible, just giving more time for the cholesterol and the bile salts and other molecules to start forming stones. Because the best way to prevent stones is to regularly empty the gallbladder. Even the NIH, the slow-moving ship of the NIH, has acknowledged this years ago, decades ago, that noting that low-fat, low-calorie diets were among the worst things you can do with slowing down the emptying of the gallbladder, thereby increasing your risk of stones. In other words, we only empty the gallbladder when we eat fat. And because so many people have been so afraid of fat for so long, the gallbladder has a very low motility or high stasis. It's just sitting there with all the stuff in it, never emptying itself. So we've ended up with this sort of perfect storm. We're eating low-fat foods, low-fat diets, which means the gallbladder isn't emptying very frequently. These same low-fat foods are almost always going to be very high carbohydrate, and I don't mean fruits and vegetables, of course, nowadays. It's going to be high processed, refined carbohydrate. In other words, high insulin spiking foods. And as insulin's going up, it's increasing the cholesterol production from the liver, enriching the bile, making it even thicker, promoting the formation of stones. Now, one interesting thing about all of this is what happens once the gallbladder is removed. And there is a study that was published in rodents, and there is no reason to think this doesn't apply to humans. This is one of those phenomena that appears to be very tight across the species. But they found that when the rodents had their gallbladder removed, there two things had happened. Both of them appear to happen in humans too. There's a higher rate of what's called enterohepatic recycling of bile. So if someone has lost their gallbladder, they would say, well, then I can never eat fat again. Well, that's not true. What happens is that the liver is able to produce bile more quickly on demand, and we allow the liver a break in a way by recycling bile and then putting it back in. So basically, we release bile into the intestines to help digest fat. That's its main purpose. And then having digested or emulsified the fat, we reabsorb that bile back into the blood, only to be again put back into the intestines without the liver having to make it this time. So we just have this rapid recycling of bile. One, that happens. We can more rapidly recycle bile to make up for the loss of the gallbladder. But two, it's interesting that when we recycle bile salts, now we have a chemical in the blood that was originally intended to just be dumped into the intestines. Now, I say originally intended, but the body is designed to have bile reabsorb. It's just happening a lot more. One of the totally overlooked aspects of bile salts is that they actually stimulate mitochondrial uncoupling in fat cells. And so these animal models show that when you have removed the gallbladder and induced this higher rate of bile recycling, metabolic rate goes up significantly in these animals. So there's this totally unrelated aspect of bile salts that when it's in the blood, is inducing the burning of fat by making our fat cells have a much higher metabolic rate. So there's this kind of delicious paradox and irony that when we eat more fat, we produce more bile. And when more bile is getting into the blood, it induces the burning of more fat. So there's a kind of an interesting phenomenon here is it's a balance between gut bile purposes and blood bile effects.
Someone on a high fat, low carb diet would have higher bile salts in their blood.
Yeah, so that's a wonderful question. I don't know that anyone has ever quantified that. I've never seen it, but I think you and I could both speculate that is very likely the case, because when you're making more bile in response, or releasing more bile in response to eating fat, you will reabsorb more bile. That's just a natural part of the process. So that's probably true.
And that may actually be a mitochondrial uncoupling trigger, which helps increase our metabolic rate.
Yep, that's exactly right. Yeah.
Fascinating. Ooh, that's really interesting. The vast majority of liver transplants are caused by alcoholic liver disease and increasingly fatty liver disease.
Mm-hmm.
And there was an interesting paper in JAMA, one of our top medical journals from last year, that said that now more than 30% of liver transplants are caused by the downstream effects of fatty liver disease, and that there are lack of effective therapies.
Yeah, well, you and I both know that conventional medicine doesn't have much training in the appreciation of dietary interventions in any disorder, let alone fatty liver disease. So it is interesting to note the evolution or the history of non-alcoholic fatty liver disease. A couple generations ago, it wasn't a thing even. It was just alcoholic fatty liver disease. And now we have this little addition to the prefix, non-alcoholic fatty liver disease. This, again, is a newer problem with regards to the history of liver problems or the history of fatty liver. So basically the primary problem, the liver is too fat. Most of the liver fat is coming from adipocytes or fat cells that are leaking that fat. The vast majority, 80%-ish of the fat in the liver is leaking into the liver from fat cells. As a fat cell is undergoing hypertrophy, it essentially starts to reach a point of maximum dimension. The physical dimensions are becoming problematic. And while insulin is continuing to force feed fat into the fat cell, normally insulin would prevent the leaking or the breakdown of that fat. But now the fat cell, knowing it's reaching maximum dimensions, in order to not get too big and explode or have to undergo apoptosis, it starts leaking the fat. So insulin-induced inhibition of lipolysis fails. And that part of the fat cell becomes insulin resistant. So we have a hypertrophic insulin resistant fat cell now leaking free fatty acids. That is the primary source of the fat that is accumulating in the liver from the leaking fat cells. At the same time, there's a more minor contribution, which is the hyperinsulinemia of insulin resistance, where the elevated insulin is promoting lipogenesis within the liver itself. Now, so those are well-done studies that have quantified by using radio-labeled or tracing fat movement in the body. Unfortunately, those same studies did not attempt to find the contribution of fructose, which we absolutely know is a contributor. Every paper that studies, every scientist, every group that studies fructose and fatty liver disease notes that fructose is a massive contributor. In fact, Luc Tappy, I think, is one of the scientists in Switzerland who studied this the most, and his quote is something like, "Fructose is the most lipogenic molecule in the liver in the body." We have some pilot studies, one from Duke, I know in particular, that confirmed, for example, a low-carb diet is effective at reducing liver fat. But we have other evidence. Basically, for me, clearing the liver of fat is the same way of clearing your fat cells of fat, that there are two ways to go about it: controlling insulin and controlling energy. Now, those aren't necessarily the same thing, but there is some redundancy to them. And so even if you put anyone on a fasting regimen that is, of course, going to lower their caloric load, there's no question the liver is going to start lowering its fat and do so very dramatically. At the same time, if you're lowering insulin through, say, a low-carb diet and or fasting coupled, then you will once again be lowering the insulin, improving fat cell insulin sensitivity, and thus removing the key contributors to the fat that's accumulating in the liver. We can have our fat tissue growing, what we can pinch and jiggle, through two different processes. One, as you noted, is hypertrophy, where each individual fat cell is getting significantly bigger, and I mean 4 or 5 times bigger than normal. Or alternatively, the fat tissue, what we can see and pinch and jiggle, and why the scale is going up every year over year, the fat tissue can be growing through hyperplasia, which is a situation where the fat cell size is actually quite modest still. They're not particularly bigger than normal. We just have a lot more of them. So we're multiplying. That's what hyperplasia is. So we have hypertrophic fat and we have hyperplastic fat. Now, interestingly, on the hypertrophic side, that's where things start to go wrong. The vast majority of people will go through the path of hypertrophic fat gain. And only a relative minority of individuals, and this is about 10 to 15% of people who are considered obese, they have this hyperplastic fat growth. So it's much less common. Most of us go that hypertrophic route because by the time we've finished puberty, late teens in girls and maybe early 20s in most boys, then we have set our fat cell number. So we're growing our fat cell number throughout infancy, childhood, and pubescence or adolescence. And then by the time we're wrapping up adolescence, we have flatlined and we have plateaued. And the number of fat cells we made at the end of adolescence is the number of fat cells that we essentially keep perfectly until we get to around 70 years old. And now we start losing fat cells. But lest that seem like a good thing, as you start to lose your fat cell number, you force a greater burden on the remaining fat cells to store the fat, thus bringing us back to the story of hypertrophy. Now, when a fat cell is getting big, which is that it starts to reach a point of maximum dimension that becomes damaging to a cell, a cell can only get so big. Every cell has its natural limits. The fat cell is reaching its natural limit, and thus it becomes insulin resistant in order to prevent further growth. So it becomes insulin resistant to save itself, little knowing that the cells downstream, which eventually would be all the cells of the body, are actually having to pick up the burden as the cell is leaking free fatty acids. At the same time, even though fat cells have a very low metabolic rate, they nevertheless have a metabolic rate, which means they need blood, they need oxygen, and they need nutrients. But what starts to happen is as the fat cells themselves are getting bigger and bigger, they're pushing each other further and further away from capillaries or from blood flow. And thus the hypertrophic fat cell becomes hypoxic or low in oxygen. It can start to secrete pro-inflammatory proteins or prototypical inflammatory proteins that, rather than inducing inflammation in cells, actually increases the formation of new capillaries. So one of the molecules that the fat cell can release is vascular endothelial growth factor, or VEGF. As it becomes hypoxic, it starts to secrete numerous pro-inflammatory proteins. VEGF in the synthesis of new blood is only one of them, but you can't really get that one without all the others, essentially. And so the hypertrophic fat cells are trying to correct the poor blood flow by secreting this whole panel of pro-inflammatory proteins in the hopes that it will improve blood flow. Because it's better to improve blood flow than to die through necrosis. That's a messy death. But in the process, it's now leaking this whole stable of pro-inflammatory proteins throughout the body. So we have the hypertrophic fat cell leaking both free fatty acids, contributing to the so-called lipotoxicity throughout the body. All these tissues are starting to have to store more fat than they want to, and at the same time, releasing pro-inflammatory proteins. And the combination of those two things partially starts to amplify the problem within itself. One, those are not only promoting insulin resistance throughout the rest of the body, because those will stimulate the production of a type of lipid called ceramides in all the other cells of the body, which is why I'm an advocate of the fat first view. It's because you have all the perfect ingredients to promote the formation of ceramides in any other tissue, like the muscle or the liver, and now you're just a step away from type 2 diabetes. People should know that there's also just a very strong genetic component to this. We know across ethnicities, people will have certain polymorphisms or altered gene expression in the genes that dictate whether they go down hyperplasia or whether they go down hypertrophy. So there's only so much we can move the needle, but we may as well move it however we can. Inflammation and elevated insulin will promote the accumulation of a type of ceramide called ceramide 1-phosphate. Ceramide 1-phosphate is a molecule that will promote hypertrophy of the fat cell, precluding the hyperplasia, so kind of closing that avenue off. And the relevance of insulin cannot be overstated, because we know at the site of insulin injection in diabetics, the reason we tell a diabetic to rotate their injection sites is to prevent the insulin-induced hypertrophy. And a study from Japan has done this, where they pulled fat biopsies of areas where the insulin has been injected chronically, and just a few inches away in that same fat pad, but where the insulin wasn't injected. And the fat cells were about 3 to 4 times bigger at the site of the insulin injection. Independent of insulin and inflammation, those signals promoting ceramide 1-phosphate, we actually have a product of seed oils. When we consume high levels of linoleic acid, we force that linoleic acid down this pathway of peroxidation. We always talk about oxidation, which is normal burning of fat, which linoleic acid can do. Linoleic acid can get burned for energy or via oxidation very readily. But alternatively, we eat so much more of it than our body knows what to do with that we can't go down that pathway all the way. Some of it gets pushed down this peroxidation pathway. Once it's gone down that pathway, it can turn into numerous harmful molecules. One of them is a molecule relevant to the fat cell, which is 4-hydroxynonenal, which is or 4-HNE. Once again, just like ceramide 1-phosphate, 4-HNE will push the fat cell down the path of hypertrophy. So forcing hypertrophy, which of course means forcing the fat cell to become insulin resistant and pro-inflammatory.
The majority of our processed foods, and processed foods is about 80% of the grocery store, are going to have these seed oils in them and refined sugar. It's kind of the perfect storm of what you're talking about, and why I think towards the end of the book, we really get into talking about eating whole foods and real foods. If it's in a package, you really want to look for it. Does this include these refined seed and vegetable oils that are going to be high in the linoleic acid? And just kind of thinking through everything you just said there and what is driving the fat cell hypertrophy, this more dangerous path compared to hyperplasia. Some of the takeaways I'm hearing is we want a diet and lifestyle that reduces our hyperinsulinemia, so keeps insulin low, avoiding fructose and avoiding seed oils.
If by avoiding processed foods, one, you're eating less fructose dramatically because you're just not drinking it. And then two, you're lowering your insulin by avoiding these other processed carbohydrates, and you are avoiding refined seed oils. If someone is doing that, they're doing it well. Glucagon does create an upward pressure on glucose. Its primary job is to make sure blood glucose is high. Now, if it had its way, it would make sure glucose is much higher than we'd want it. Once upon a time, and this is just a couple decades ago, normal glucose levels were considered anything below 150. And I'm just cynical enough to think, why have we lowered that? Now, on the generous side, we would say, well, because we found that if it was higher than that or around there, it was really catastrophic to health. That might be true. That might be true. Alternatively, it's also a wonderful way to diagnose people with a disease and put them on drugs much, much earlier. So by lowering the threshold, a lot more people are getting over that bar. You know, when glucose levels were considered normal up to 150, not a lot of people were getting over it. Thus, few people were being diagnosed with the problem, and there was much less drugs to be sold. By lowering that bar, that threshold, now a lot of people are just stepping right over it because it's so low. So I am admittedly a little bit of a cynical guy as I'm getting older, but also I'm too aware of the fact that in diabetes or prediabetes insulin resistance, it's insulin that's really causing the primary problems. It's not the glucose. Now, I'm not saying glucose is benign. I'm not saying that at all. There's no question it can contribute to problems. In fact, even catastrophically, when it comes to like dumping glucose into the urine and lowering blood volume and the person going unconscious. But that's very uncommon, and it's glucose levels that are up into the 200s when that normally starts to happen. The average person is sitting at a state of normal glucose, yet hyperinsulinemia because of the insulin resistance. And this is the person who's starting to experience cognitive decline, which is an area of research in my lab where it's an insulin problem, the insulin resistance of the hippocampus. They're starting to experience hypertension. They're starting to experience auditory issues and infertility, fatty liver disease. These are not problems of glucose. These are problems of insulin. So if I see someone who's on a low carbohydrate diet and their insulin is at 3 microunits per mil and their glucose level is at 100, I am inclined to give them a high five because to me, that's a perfectly healthy range for the person to be in. There are a couple known distinct biochemical problems when glucose is chronically elevated. Glycation is one of them. And of course, the hemoglobin A1C or hemoglobin glycation is a test in order to kind of capitalize on that. The hemoglobin A1C test came into vogue and basically single-handedly killed the oral glucose tolerance test because it was thought that the A1C is going to give us a better overall information than an oral glucose tolerance test, which I believe is not at all true. There's no question that glucose is a problem. I, however, don't know that it's ever been quantified. Measuring the degree of glycation from, say, 85 to 110, is it really moving the needle that much? I don't know that it is. I've not seen that quantified. I've never seen that really put together well. So I'll be a little agnostic until we can see something, and I'll continue to kind of poo-poo it. But the dynamic test is not the same as the fasting test, because if someone can't get their clinician to do an oral glucose tolerance test, and that would not be easy to do because it takes a lot of time at the clinic, and time is money, where you're having to sit around and go in for multiple tests, you can do it on your own. That is what is so powerful, is that while I am somewhat indifferent or don't have too much respect for just chronically measuring fasting glucose, because insulin could have changed years before the glucose is changing. That is not the same as that static measurement of glucose at a fasted state coming into the clinic once a year is not the same as the dynamic glucose changes that can happen when we're eating foods. And someone can see, I've eaten this carbohydrate heavy food or whatever it may be, and oh my gosh, my glucose levels spiked up to high hundreds and it stayed elevated for 4 hours. The dynamic view of glucose, I think, has tremendous diagnostic value, because if someone is insulin resistant, another outcome of this is typically going to be a glucose intolerance. If you're insulin resistant, you're going to generally be glucose intolerant. Now, you can be glucose intolerant and not insulin resistant for other reasons, but nevertheless, if you are insulin resistant, you will have some degree of glucose intolerance. So you've eaten that carbohydrate-heavy snack, and it's going to take you a long time to clear it. And it might be really messy on the way. You've come down and you're right back up, and now you're high again. It's dropped and come back up. All that kind of noise is a warning sign. And you don't get that noise when you just measure one single moment in time, or in other words, the fasting static blood glucose test that everyone goes in and does, and that we're all content with because too few of us know that there's another option.